Your passcode has been confirmed. If you need technical assistance during your call, please press star followed by 0. After the tone, please state your name. Thank you. There are 38 parties in conference, including you.
Click on the hand icon in the upper right corner. This will display your name to the meeting presenters. I will call on participants as their names are displayed. Please state your name and affiliation before asking a question and/or providing a comment. You can raise your hand during the presentation, but we will wait until the discussion period to address those comments. Also, to let you know, the session is being recorded. With that being said, I would like to have Dr. Tom Adamkiewicz give his introduction. He is going to be talking to us this afternoon about iron overload in children with sickle cell disease. Dr. Adamkiewicz?
Thank you very much, Melissa. Thanks for me to give this talk, and welcome everybody. So I will have a discussion later on. So today's topic is the iron overload in patients with sickle cell disease, and perhaps I'd like to sort of perhaps present the issue from different angles. One is perhaps to review a little bit some basic notions about iron, then go over some aspects of about hemoglobinopathies, basically conditions that require transfusion and are thus iron overload. And then we will compare a couple hemoglobinopathies, thalassemia major with sickle cell disease, to see whether we can learn one from the other. And then we'll look at some of the methods to measure iron, and finally we'll finish up with some short part about managing patients with iron overload, and finally the challenges for the future. So I'm part of the Morehouse School of Medicine, and also this is part of the NCMHD Southeastern Exploratory Sickle Cell Center of Excellence, which is based out of Medical College of Georgia and in collaboration with Morehouse School of Medicine at University of Florida. So can I have the next slide, please? So the first thing about iron is it's actually a pretty amazing compound, and it's really required for all life forms. Plants, microbes, animals. There's sort of a war between humans and I mean animals in general and microbes, because it's almost like it's a precious metal for life. And there are these special molecules, proteins, the heme proteins, that are involved in many aspects of life, including oxygen transport, hemoglobin to myoglobin, in the production of energy and electron transfer, in chemical catalysis, and also an active membrane transport mechanism. So it's a very important part of life. Can I have the next slide, please? So in terms of iron, we have between 2 to 6 grams of iron, depending on gender and age. And mainly hemoglobin is found in hemoglobin, and as well as in storage areas in the liver, in the reticuloendothelial system. There's just a little bit of iron in circulation in the plasma. It's a small amount, and we'll talk a lot about that. Now, about 1 to 2 milligrams of iron is absorbed daily, and about the same amount is lost. And the important point about the loss of iron is it's totally passive. We don't have any mechanisms to get rid of iron because it's a precious thing to us. So we want to keep it inside our bodies, and we have developed no mechanisms to get rid of it. And that's going to be an important thing, as we'll see. About 1% of the erythrocytes are recycled each day by the macrophages, which amounts to 20 milligrams. Next slide. Now, another important thing about iron is that it's a very reactive and compound, and it generates the superoxide hydroxyl radicals through the Penton reaction. this is really important because alone, this is actually pretty toxic and can cause damage intracellularly in lipids, proteins, and cause cellular damage and apoptosis. So in order to handle this, the body, nature has developed all sorts of mechanisms. And there are several key proteins, keratin, which is used for intracellular storage, and transferrin, which is used for extracellular transport. And we'll talk more about that. Next slide. So ferritin is actually mainly an intracellular protein, and it's actually composed of 24 subunits and made by two separate chromosomes, encoded in two separate chromosomes. There's the light chain, and it's found more in the liver, and then there's the heavy chain, which is found more in the heart. But you have in these sort of subunits can include both the light chain and heavy chains. The important thing about the heavy chain is that it has an enzymatic property and can transform the ferrous to ferric iron. What we measure in the blood is actually the light chain, and that is actually iron poor, and it's excreted actively in response to iron and inflammation. But amazingly, we don't know what it really does and even how it is excreted. It's such a common test, but we know actually very little about this circulating form of ferritin. Next slide. There's two key systems that have been discovered in the last 15 to 20 years of regulating iron inside the body. The first system was discovered was the iron regulatory proteins responsive elements, which is a very elegant system of basically regulating RNA translation of proteins that are involved in iron homeostasis. And there's important proteins like the divalent metal transporter, which transports the iron inside cells, including in the brush border of the gut. There's keratin, as we already mentioned, which stores iron inside the cell, and transferrin, which transports iron in the plasma. And recently, in the last 5 to 10 years, there's the whole story around hepcidin, which is still a very evolving story. This is a key protein which is involved in regulating, considered like the master regulator of iron, and this works by blocking the iron efflux transporter from basically transports the iron from inside to outside of the cell. So we can have the next slide. So this is a little bit in condition of low iron. As you can see, the transferrin receptor goes up, and the divalent metal transporter goes up, and ferritin actually goes down. And what this causes is basically it allows a influx of iron in from the gut inside the body, because the iron goes right through the cell and then is transported out through the ferroportin transporter into circulation, and then hungry cells for iron inside the body will further absorb this iron. So there's this sort of system that basically allows the iron to be transferred from the outside world to the inside world. But in situation of high iron, next slide. So a little bit of the opposite happens. All these mechanisms are shut down. The production of these proteins are downregulated, and ferritin is upregulated. And so the ferritin acts as a sort of like a storage and base of iron, and this iron that is in this dangerous species of iron is basically protected by the ferritin molecules. Also, what happens at the same time is this totally separate system, the hepcidin system, basically goes and blocks the ferroportin molecule and prevents iron from leaving the cells. And this is actually a very complicated system, the regulation of hepcidin, and still being worked out, and but we're not going to get into that today. Next slide. So that's really the story of iron in normal daily life. So what about iron overload? Well, first of all, who gets iron overloaded? There are basically two basic groups of patients. One is it can happen through genetic abnormalities. In fact, a lot of those proteins around the hepcidin were discovered because those are patients that had hemochromatosis, and we're not going to talk about this. But there's another group of patients that require chronic blood transfusion. And as I said, we have no way of getting rid of iron, and with each blood transfusion, we get this sort of injection of iron, and people that get chronic transfusion, they basically build up iron. Hemoglobinopathies, and those are some numbers from the world, around the world, from Dr. Weatherall. And basically, as you can see, there's about 250,000, maybe 300,000 people that are born with various hemoglobinopathies around the world. And many of these patients require chronic blood transfusion. There are also other conditions, anemias, myelodysplastic syndrome, that we're not going to talk today. Next slide. So why hemoglobinopathy is common, as you all know, it's mainly a protective mechanism. When one is a carrier, it makes one resistant to malaria. And that's why hemoglobinopathies are common in parts of the world where malaria is common, in sort of like the equatorial belt around the world. So next slide. So thalassemia major is a genetic disease, and so when one has only one mutation on one chromosome, then one is not sick really, and that is kind of confers a protective condition. Whereas if it misses, if one cannot produce any beta globin, then that causes a very severe form of anemia. Next slide. Now, it's a complicated slide. I'm not going to go over this at length. But the reason why this is a severe form of anemia is actually not for the reasons we think, because of the lack of production of beta globin. It's because there's a mismatch of the hemoglobin, the way hemoglobin is assembled, and there's an excess of alpha globin, and this excess is actually toxic. Next slide. Next slide. And it causes the marrow to try to produce blood because these cells cannot really mature out normally. And so it gives these kind of weird shaped red cells, and you can see some nucleated cells. Slide. And so this causes massive sort of expansion of bone and deformity and anemia, and untreated, these patients die within as children, basically, in the first decade of life. So about in the about 20, actually more like 40, 50 years ago, people discovered that by transfusing these patients, one can avoid all these problems. But unfortunately, with transfusion came another price, that these patients got transfusions, and the transfusion itself became toxic. Slide. So this is what happens. So the more people are transfused, there's this sort of organs that get hit by the iron overload. And that's because we talked about these species of iron that basically are in circulation that are not being sort of protected. It's the non-transferrin bound iron, and that goes intracellularly and damages the endocrine system, damages the heart and the liver. And eventually these patients die from these complications. So the idea is, to try to treat that, and for that we'll talk about the chelation agents. But before we talk about chelation agents, let's see how the sickle cell disease compared to thalassemia major. Well, sickle cell disease is also a problem with hemoglobin, but instead of not producing the beta globin, it produces an abnormal beta globin, which under certain conditions becomes polymerized, produces these sort of spaghetti strands and these sort of banana-shaped red cells that clog up vessels. Next slide. And so when this happens, it can also affect multiple organs since there are blood vessels all over the place. Next slide. Now, one complication patients with sickle cell disease have is stroke. And nowadays we can prevent stroke, next slide, by screening patients with transcranial Doppler. Next slide. So, on chronic transfusion.
I'm sorry, Dr. Adamkiewicz. I just want to interrupt a moment just to remind everyone to please put your phones on mute. Thank you.
Thank you. So chronic transfusion here has been shown to prevent stroke in children with sickle cell disease, are found to be at high risk because of high velocity with the transcranial Doppler studies. Next slide. But the problem is that these patients will, again, develop iron overload. So let's just go over some slides. Those are slides from Dr. Brittenham's recent paper in New England Journal that you may have seen already. So patients with sickle cell disease, it's just a normal patient. So you can see that what happens is iron is absorbed through the gastrointestinal system, is transported with transferrin, goes to the marrow, red cells are produced. Then red cells are when they die, eventually, within 60 days or so, they're going to the endothelial system, and the cycle continues. And some of the iron goes to the muscles and the rest of the body, and to the liver. Next slide. In sickle cell disease, this system is revved up because they die much quicker than within 5 weeks. Next slide. And so what happens is that in these patients that are put on chronic transfusion, basically they build up these huge stores of iron, both in the reticuloendothelial system and in the liver. And eventually what happens is the iron leaks out of all this and basically goes and poisons the heart and the endocrine system. Next slide. So the idea is to give chelation agents, basically compounds that basically bind iron and from these iron pools, as well as help detoxify the organs that are hit. Next slide. So here are some of the compounds. The first compound used found was dipteroxamine, which has been used since the early 70s. It's basically a bacterial compound. It's a chelating agent produced by bacteria to try for bacteria's sake. And so it sounds to be actually quite effective. The only problem is it's a fairly large molecule and has to be done given subcutaneously. So it's a pretty painful process. Basically, 5 nights a week, the patient has to give for 8 to 10 hours an injection of this medication. Also, these compounds have toxicity. If you remove too much iron, that causes damage. It can cause damage to the eyes, to the hearing system, and growth retardation. This is mainly excreted in the urine and the bile. Next. Now, recently, there's another compound that was discovered about or tested about 10, 15 years ago. This right now is not approved in Canada and the United States. That's diphtheria-prone, but is available in Europe. This is not right. Is associated with so it's a smaller molecule, so it is absorbed and it is associated with some toxicity. So and that neutropenia is one of those, and gastrointestinal disturbances. And we'll talk a little bit more about this next. And finally, there is a Deferiox, which is or XJ, which is the new oral chelator, which is now approved in Canada and the United States for the last 6-7 years. And this compound is a tridane, so it's got three ways to bind to iron, and it basically complexes 2 to 1 per iron molecule of iron. And this is probably the most commonly used right now compound in the United States and Canada and throughout the world. So here again, this is associated with toxicities, and we'll talk about this at the end of the talk. So all these compounds require attention. But the thing, before we talk about these chelating agents in further detail, I really want to concentrate is on the issue is how to measure iron. You would think that iron is an easy thing to measure, but it is not. Several ways of classifying iron measurement tools. There's only 3 of them that actually measures iron directly. One is to measure the amount of iron removed, and we'll see how that's done. Another is to take a piece of tissue and measure how much iron there is in that piece of tissue. And finally, because iron has magnetic properties, one can measure iron using the magnetic properties of iron. So those are the 3 direct measures of iron. All the other measures are basically indirect. And basically, it's the body's response to iron overload, either physiologically or because of tissue damage. And so we'll talk about these different measures and how to use those to monitor patients next. So the amount of iron given or removed. 1 ml of iron, of a red cell, contains 1 milligram of iron. So this is a nice little neat thing to know, because then one can calculate how much iron one gives or one removes. So for example, one can assume that, let's say, an average unit of blood contains hematocrit of 60%. So based on these 2 things, one can calculate that transfused blood at a rate of 10 cc's per kilo every 3 weeks gives an iron load of 0.3 milligrams per kilogram per day. And we'll come back to that. So that's one way of doing it. Another way is to remove iron, and this is a very elegant study from the Italian group. So these are patients with thalassemia major that were transplanted, so did not require transfusion anymore, but were iron overloaded. So they measured the liver, and then they compared the liver iron measurement to how much iron they removed from the body using phlebotomy, and they did this very carefully. And they found that when sample sizes were of good size, they got a very good correlation between the liver iron and the total iron body store in patients with thalassemia major. If the samples were size, there was more variability. Next slide. We did a study using 2 NIH sponsored studies, the STOP study. So those were studies that looked at whether chronic transfusion works to prevent stroke for patients at risk because of increased velocity in the transcranial Doppler measurements. So we went back and took data. Next slide. Next slide. So what we did was we went back and asked for the data on liver iron on patients that had those done. And we compared to the available data that was collected as part of the clinical trial. And so there were 271 patients. They were followed almost for 10 years, 8.5 years. And so most received transfusions within a month. Finally, the dose was usually 11 cc's per kilogram per transfusion, and most patients were receiving some form of chelation therapy eventually. Next slide. So there was 103 patients that had liver biopsies. Now this is important because it was kind of interesting to find out that actually it's not a benign procedure. There were 3 patients with complications. One was a severe complication. The patient had a liver abscess and required surgery and was pretty sick. and there were a couple patients with significant pain episode requiring hospitalization in one case. The other interesting thing about this study was that people used a variety of different methods, and that's going to be a bit of a recurrent theme. And some of them are more or less standardized, so who knows how comparable those are. So we concentrated on those. This is a method used by the Mayo Clinic and also by ERA. This other method was used by Dr. Brittenham, and that's a very well-standardized method. Next slide. So before we talk about the comparison, we found that, serum ferritin is actually fairly well basically reproducible. So if we compare serum ferritin done at the study lab versus those done at the various hospitals, there was a fair correlation between both. Next slide. So, if we looked at this is the two studies put together, the data, and that's almost like 10 years worth of data. So the interesting thing is those are patients that are receiving prophylactic transfusions. And yet you can see that serum ferritins that's the mean sort of median serum ferritin, rose about 3,000 by the two-thirds of the study period examined. So most patients get iron overloaded despite chelation therapy. Yeah, well, that's fine. This is good. This is good too. This is good too. The other interesting thing about this study is that as patients got iron overload based on the liver iron measurement, the ferritin curve appeared to be flattened first and then rose again. Can we go back one slide? The same thing when we measured iron by the amount of blood transfused, so that's pre-chelation, the curve seems to flatten. Next slide and next slide. So what we found was that basically, you can increase iron load pretty significantly, but you look at the ferritins, they don't change that much. So that tells us something about ferritin, that we got to be careful about how we use ferritin. It seems to reach a bit of a plateau here, or a flattening of the curve before it rises again. Next slide. So one thing that we sort of suggest as part of the study is that ferritin, low levels of ferritin are fairly reliable indicators of low level of iron measured by the amount of blood given. High ferritins are also reliable indicators of high levels of iron. Next slide. And the same thing can be said when you use liver iron concentration. But ferritins are not terribly reliable indicators in that sort of middle range. Next slide. The other thing is about ferritin is that it's not only a measure of iron overload, it's also a measure of liver damage. So as the ferritin levels went up, the percent of patients with abnormal ALT went up equally. It's almost like in a sort of a nice sort of a curve here. Next slide. So in summary, what we found was that, like I said, sort of low level of iron means that iron level is okay most of the time. High levels of serum ferritin means that most of the time there is significant iron overload. The problem is in this kind of range, it becomes a little iffy as a measurement. Next slide. So what other measures do we have? So the next system, next slide, is the SQUID, which is, back. So it's a superconducting quantum interference device. This actually measures the magnetic properties of the iron that's stored in the liver. Now, unfortunately, it's a good machine. Unfortunately, it's pretty finicky and it's experimental. And there's only like 2 machines in the United States and a couple in Europe, and so it's not readily available. So what is next? MRI actually, in the last few years, really sort of flourished as a novel method. It's non-invasive and it's totally empirical. it's not a direct measure of iron, contrary to what I initially thought. It actually measures the reaction to the iron, intracellular reaction to the, it's the intracellular reaction to what the iron that's inside the cell. And we don't quite understand what it measures. It probably measures a interaction between the ferritin and the hemosiderin intracellularly with the iron and the water. And but this is still being worked out. There are some issues. The methods by empiricism are getting better, and with better methods of calibration and optimization of protocols. There's still some challenges about the availability and standardization of this method. Next slide. So those are some of, I hope there's no MRI experts, because those are sort of cheat sheet things for me. But there's basically two methods that are used. There's the T2 and the T2 star. Basically, those are some basic properties of acquisition of the MRI signal using different physical properties. So it's basically two different type of measurements. Now, another important thing is we hear often about the R2 measurements and the T2 measurements. The R is basically 1 over the T, okay? So that's something that's kind of useful to know. So the T2 and T2 star measurements are basically milliseconds, and it goes in the reverse direction of iron overload. Whereas if you do the 1 over T2 or 1 over T2 star, which is the R2 star, it's in hertz, but it goes with the direction of iron overload. When people report liver iron measurements with MRIs, it's using the R2 or R2 star, okay? Whereas for the heart, it's expressed as T2 star usually. So the other important point is that usually these are interchangeable between different brands of machines, but not strength of machines. Calibration has to be different if you use like a stronger, the newer, stronger machines of 3.0 Tesla. Next slide. Next slide. Okay. So here are some calibration studies. So this is from out of Australia. This is out of LA. Here. And as you can see, this is comparing liver iron measurements by biopsy to basically, this is R2 and this is R2 star. And you have a bit of a curve here, and here is a pretty straight line. So it seems to be pretty nice curves. Next slide. This is some newer protocol at St. Jude, basically where there is basically a gating and taking away of the blood vessels, precision, and as you can see, you get further improvement in the lines, the correlation between the liver iron and the measurements from the MRI signal. Thanks. Next slide. Now, another measurement is the iron that accumulates in the heart. There's a lot more data about this in thalassemia than in sickle cell disease, and I'm not going to get into that a lot, and it's usually expressed in the form of T2 star, with 20 milliseconds being okay, and with less than 10 milliseconds being severe iron overload. There is, in thalassemia, this is becoming like the sort of benchmark for increased treatment in that patient population where iron overload in the heart is a significant problem. That's still being worked out. Next slide. So let's start doing those MRIs. Well, the problem is they're not that available still. I just called yesterday to find out what is the latest availability. I called some of the companies. So GE, for example, has a R2 star package in their new machines that could be retrofitted up to 1 year back into the older machines. For the other brands, Simon, Phillips, one can get T2 star R2 results straight from the machine readings, but there's no processing. That has to be added as separate from what's offered in the computer package. Now, the folks out of Australia developed a service called the FerryScan service, where they will take this kind of data from any of those machines and process it, send electronically, it's processed, and they send back a result. So that's the FerryScan. Now, the folks at St. Jude's, they have a protocol, but it's really a research protocol at this point. And so hopefully this is an area that's going to improve over time. Okay, so we talked about some of the measurements of iron. Now, what is another possible measurement? We know that iron is toxic, so what about measuring the toxicity that it causes to individuals? And what is the difference between sickle cell disease and thalassemia major? Next slide. So this is a study out of the Oakland group where they basically showed that patients with sickle cell disease on chronic transfusion compared to those with thalassemia actually don't get as tight a care as the patient with thalassemia. Next slide. But what about organ dysfunction? Well, the interesting thing in these groups, which may or may not be entirely comparable, is that cardiac disease seems to be more frequent in patients with thalassemia, as well as endocrine abnormalities and liver disease. Next slide. So let's look at liver in more detail. So, patients with thalassemia disease, thalassemia major, tend to have more fibrosis than patients with sickle cell disease. And we found that as part of our study in the STOP patients. There were very few patients with significant fibrosis amongst that 103 biopsies that were done. And patients with sickle cell disease tend to have more storage of the iron inside the reticuloendothelial part of the liver. Next. What about endocrine disease? Well, endocrine, here seems to be a significant difference between the two diseases, with the thalassemia major patients having a lot more endocrine problems, hypogonadism, growth hormone treatment, height issues, hypothyroidism. There seems to be a big difference between both groups. Next. Same thing with bone problems. Patients with thalassemia are more prone for fractures. Next slide. What about cardiac? Next. So here again, patients with thalassemia major are more likely to have cardiac disease and also cardiac accumulation of iron in the heart. Now, it's we've got to be careful how those studies are compared, because they may or may not be entirely comparable in terms of transfusion length and age and all that, but more or less this trend persists. Next. What about the spleen? Well, interestingly, patients with sickle cell disease, we were taught that the spleen is dysfunctional and doesn't exist, but actually on chronic transfusion, it sort of resurrects, and actually on MRI, you can detect iron accumulation in the spleen of patients with sickle cell disease. Next. Now, what about then this non-transferrin bound iron, that bad iron that's circulating? Well, there are a couple of studies. I'm just going to show one where patients with thalassemia major, for some reason, seem to have higher levels of the non-transferrin bound iron. Next slide. So what about these injuries, the injury resulting from that? Next slide. And here again, in this study, so basically what they show is that the malondialdehyde, which is a marker of oxidant injury, is higher in patients with thalassemia than sickle cell disease, and certainly both are higher than the controls, whereas vitamin E levels are higher in patients with sickle cell disease, and inflammatory markers are higher in patients with sickle cell disease. Next. So how does this translate into mortality? Next. So there's this classic slide from several, like this is almost 20 years old, that patients with thalassemia major with high ferritin levels were significantly higher risk of dying cardiac death than those with lower ferritin levels. Now, this data is not transposable to today because these patients, there's a lot of patients with hepatitis C at the time, so there were other reasons that may make these patients sick. But nevertheless, there is this association. Next. So here again, unfortunately, the data is limited, but this is a study from the Oakland group where they compared patients with sickle cell disease on chronic transfusion with those with thalassemia major. And those were patients that were iron overloaded based on the serum ferritin, I believe was above 2,000 on both groups, or high liver irons. And basically, out of these groups, the patients with sickle cell disease, more patients with sickle cell disease died. And when one looked at only patients that were 21 years old, more patients with sickle cell disease died than thalassemia major. But it looks like a lot of these patients died because they had bad sickle cell disease. And so it's unclear and unlikely that it was related to iron overload. It seems to be more like they had bad sickle cell disease. In fact, cardiomyopathies were actually pretty much similar in both groups. So this remains still an unanswered question. However, to me, even though patients with sickle cell disease on chronic transfusion seem to have less of some of those diseases, classic diseases that we see in thalassemia from iron overload, mortality at best seems to be the same. So we need more data. Next slide. So where does this bring us now? So what are we supposed to do with patients on chronic transfusion? So this is a slide adapted from Dr. Brittenham. Basically, he had a very complicated slide with cardiac iron overload, and I didn't put heart overload because that's infrequent in patients with sickle cell disease, and you can look it up in the article. But basically, this point is that you have to stratify by heart iron, by liver iron, and how much patients is transfused. So basically, on this kind of stratification, you can there are basically three levels of iron treatment. Basically, if there's no iron overload, then you don't give treatment because you're going to get toxicity from the chelators. When there's mild iron or moderate iron load, you start at 20 milligrams per kilogram of deferoxyrox, and deferoxamine is going to be 30 to 40 milligrams per kilogram per day, and then you're going to give higher dose of Exjade and higher doses of DFO with higher liver irons and with higher concentration of iron transfusion. Next slide. How to translate this with, if you don't have access to an MRI scanner to measure, or you don't do liver biopsies? Well, it becomes tricky, and I think one could use ferritin. Certainly those really high ferritin numbers, I think, warrant an increased amount of chelators, whereas low levels of ferritin persistently, say that it's okay to give a reduced dose of chelators, whereas low dose is to stop the chelation therapy. Although even that one has to be careful because some of those patients are low responders to iron overload. So I'm just saying that one could use those extremes, but in this sort of gray area, one has to be really cautious. And that's why it probably is worth doing a liver biopsy if you, maybe every year, every 2 years at least, to really find out where one is in the iron treatment. Next. So this is, those are some of the things to follow on patients on chronic transfusion. to make sure that all the ducks in a row. Basically, patients come regularly for transfusion on a monthly basis. I think that with the potential problems with the chelators, there's a label now with XJ, with especially in older patients with gastrointestinal bleeding, kidney problems, liver problems. I think being aware of these issues and checking on them on a monthly basis, at least with a nurse's check and doing a height and weight, and at least every 3 months PE is something that's worth it, if not monthly, especially patients that have some of those issues, rising creatinine, liver function tests that are rising, etc. So I think I would say that this requires caution, and since the patients are coming regularly, it shouldn't be that much of a problem to collect that information and finding out how the patients are doing. The liver function test should be at least done every 3 months, if not monthly, when their patients are on chelation therapy. How often to measure liver iron? Iron ideally should be annually. Again, liver biopsies are not a benign procedure, and it's good to work with a GI guy or person, gal also, that will do that has experience and does it under ultrasound guidance. How are we doing with time?
You've got about 2 minutes according to our schedule. We'd like to start questions at 2:50. Okay.
All right. So anyway, and then especially with XJ, requires frequent monitoring of kidney function. And there's the cardiac evaluation. Echocardiography is useful. However, it doesn't seem to correlate very well in patients with sickle cell disease with the iron overload of the heart. There's a nice paper out of St. Jude about that. But it's still worth doing, and also doing a simple thing like an EKG, looking for dysrhythmias. Finally, endocrine evaluation is particularly important in patients with thalassemia. Whether those need to be done that frequently in patients with sickle cell disease, I think is debatable. And finally, really important to check at least annually the retina and the hearing for toxicity of the chelators. So this is a patient from the STOP study, and as you can see, the ferritin goes up. At the same time as the ferritin goes up, the ALT goes up, and there's intensification here of the chelation therapy. Those are the liver biopsies. They start coming down, and both measurements come down. So, of course, that's the nicest graph out of the lot. So, next slide. Now, this is a big challenge. It's that this was a poster from 4 years ago, but that most patients with disease on XJ actually, after 3 years, most of them, or at least, most of them were still on it, but barely. So, taking the medication, even the oral one, can be a challenge for such a long period of time. And here you could see that as you increase the dose, the ferritins start dropping. So this means that it really requires close attention to the lab results and following those lab results and adjusting the doses. Next. So basically, in summary, we can see that there are differences between thalassemia and sickle cell disease. So patients with sickle cell disease seem to have less liver, heart, endocrine problems, maybe because the non-transferring iron is less, there's more inflammation. But the mortality, I don't know, but the data is pretty limited. Next. So we need more, there needs to be more population data, I think, and we need to do a better job at making MRI protocols standardized and available to all. And basically, and we need to find out what iron load does in patients with sickle cell disease. Does it make sickling worse? What happens to those patients that graduate from pediatrics to adult care? So all of those are questions for the future. That's it.
All right. Thank you, Dr. Adamkiewicz. We will now open the lines for questions. Please remember to keep your phones on mute when not speaking. If you have a question, please raise your hand electronically, and your names will be called on in the order received. We only have this line scheduled for an hour or so, so I will need to stop the session when we reach that time point. And if you have any further questions for Dr. Adamkiewicz, please feel free to contact him at the email address that is on the slide in front of you. So our first question comes from Mac Steele, sorry. Are you there, Mr. Steele?
Actually, I didn't have a question, but I do have one since I was called. We're in Canada here. I was just curious a little about the availability of XJade for your sickle cell patients for chelation. Are you, in general, are you able to use it as a first-line therapy, or do you have to prove failure on Desferal first? I don't know, just general experience.
Well, here in Georgia, it's available as a first. Hello? Dr. A?
Dr. Adamkiewicz?
Yeah,
Yeah, go ahead.
It's available as a first line, at least here in Georgia. Hello?
Yes,
Hello?
Thank you.
Did you get that answered, Mr. Steele?
Yep, thanks a lot.
Okay. Are there any other questions on the floor?
I have one. This is Jonathan Stiles from Morehouse School of Medicine. And I just wanted to find out, in developing countries where you have problems with infectious diseases, transmission during blood transfusion, do you know anything about what is done in the developing countries relating to iron overload?
Yeah, hey, Jonathan. Yeah, that's a good question. In terms of, for example, in the Middle East, I think there is a pretty much, and in India, I think the chelation agents are used are available basically, and I know they're being used. In sub-Saharan Africa, I'm not sure. I haven't spoken, but I suspect that they're available in larger urban centers. Sure. But I think that there are huge issues in terms of putting people on chronic transfusion, in terms of making sure the blood supply is safe and all that. And I think some of those things are being worked out, and cost versus benefit and all those kind of issues. For XJade, the price could be $20,000 to $50,000 per patient per year.
Right.
So it's extremely expensive.
Mm-hmm.
And so, and as you know, like in Jamaica, they don't transfuse patients on, and because it's who have stroke, for example. Sure. And people have been saying that stroke is not common or less common in Africa, and that's not true. I mean, patients are just as risk for stroke in Africa. So I think it begs also the question, what other therapies are there, and is there something else that could be done other than transfusion?
Right. Thank you.
Are there any other questions? Okay. Well, thank you so much, Dr. Adamkiewicz, for your time. Our next webinar will take place on Thursday, April 28th on newborn screening engagement with the community by Dr. Alison Streetley from the UK. It should be really interesting, and we urge all of you to join us again next month. If you have any questions about the webinar, please to contact Shape at spope@cdc.gov. All for your participation. Have a great afternoon.
Thank you.